movement. If you're listening on a podcast player, you can go down to the bottom and subscribe for other topics we've had on hip impingement, labral tears, sports hernias, knee conditions, and etc. If you're listening on YouTube, then obviously we have video, but ideally you don't need to watch the video. There's nothing happening on it. You just have to listen in and subscribe to the regular show. Now, I will be sharing today a topic of one of the comments that we had on at least one of our emails. By the way, I will be picking some of these questions and topics based upon emails, phone calls, and even comments to our YouTube channel. We can't give you medical advice directly, but it's easiest just to address them all in turn like so. Also, on your Spotify player, you can actually comment in there as well. I'll start to make some comments on, answer some comments when we can. Now, the topic of the day is going to be about hip or groin pain that follows, I don't want to say follows, that is still present even after having a hip repair. So, we've had countless people over the years in our practice come in after a resurfacing of the hip, after they've quote unquote corrected the hip impingement, and also people after they've had hip replacements. So, how can you possibly have it if it's been quote unquote fixed? Now, I'm not going to say I'm going through this to demonize surgeries. There's a time and place. I've sent people to surgery myself. Mainly because there's, again, certain circumstances. But just because you failed care with something or you're in pain doesn't mean you need to have surgery for anything. But there's many reasons why the phenomena of having continued pain in the groin can still happen, even though you can't possibly, quote, have hip impingement because it's been repaired. By the way, if you guys have comments or questions as we're going along with this, if you're on YouTube, start dropping them in the bottom. I'll do my best to answer. I do this on the way to work, so I can't always look at the screen, but I'll see if I can answer some theories. Again, I can't give you personal medical advice. Now, I can tell you that I remember there was one man that we worked with, that he actually had, he went one of the best places to have hip resurfacing done. He was in his 30s at the time. He was told he had hip impingement. And they debrided the area. They made it right as rain, and so he couldn't have hip impingement, he said. And so, lo and behold, he comes in and he has the stereotypical hip impingement symptoms. Pain with deep squatting positions, front part of the crease of the hip, sometimes refers to the sides. It's very uncomfortable to do things like bring knee to the chest or knee to the opposite shoulder. And there's actually a series of tests that we do, and actually we direct people on our telehealth sessions as well, to do self-directed hip impingement tests to see if they are in that category, in that box of that type of groin or hip pain. And one of them that we do, at least for the classic in-persons, is going to be Feder's test, Faber's test, Scour's test, circumduction, axial compression, and then also we need to do an examination to investigate the lumbar spine, and also loading mechanics. Simple things like doing a squat analysis to see how you're squatting, where your frontal plane drift is. Are you loading that side more or less? And also looking below the area to see, is there any reason why the hip would be getting unnecessarily loaded more? Is there an old knee condition? Do they have a prosthetic foot, etc.? So there's a lot of reasons, and everybody's a little bit more more individual with this than I think the internet would lead you to believe. If you're only looking for conditions like how to solve hip impingement, they'll start talking to you about, like glute exercises and stretching and so on of the hip, but not very often do you get specific recommendations and good ones, targeted ones for areas around, because you need to have an examination or an assessment to see if there's any deficiency of strength or flexibility in those areas. Because if you do have a limitation of the foot is stiff, you have an old Achilles injury, yes, it will put an excessive load onto the hip, even though you do have a quote-unquote perfect hip now. There's also a core component too. I don't want to say weakness, it's just is it resilient enough to keep in place? And there's also default settings, which are like software patterns. Too much anterior pelvic tilt doesn't help out the matter with people with hip impingement, whether they have true hip impingement or they have referred hip impingement from overactivity of musculature in the area, or they have it from a lumbar spine component. So let's recap here. Is it possible to have hip or groin pain after having a hip resurfacing or a hip replacement? Yes, it is. Probably less possible after a total hip replacement, but the resurfacings are actually more common than you think. Someone had asked recently about like maybe the scar tissue overgrew again, and it's now the scar tissue is creating a problem. In my experience, probably not. Yeah, anything's possible, but are things probable? TBD. But I think if we narrow down the possibilities and start checklisting off the things that are more probable than not, I think we arrive at a better answer. So let's just play this game here with me. And if we have the 4 basic possibilities of symptom generation into that area are going to be, number 1, bony changes, or we'll say joint changes. And so that would be arthritis, hip impingement, which is a bony change of the acetabulum or the pelvis above it. It could be of the femur itself, where it's more shaped like an egg versus a ball. And I would put labrums in this category too. It's more of a cartilaginous type of injury. Even ligaments would be in this. So is there any problem with these? If we're talking about someone who's post-op hip resurfacing for hip impingement, I don't think these are possibilities. You think about the things that someone needs to go through to get this procedure done. They had x-rays and imaging done, so there's probably not any big bad arthritis in there that's so severe that it needs to be replaced, or else they probably would have replaced the hip. Is there a labral tear? Well, if there was, I bet the person would have gone in and probably addressed that while they were in there too. Is there impingement? Well, they probably addressed the bony component to it. So probably all these things are off the board, unless it's early on. Sorry about that. Unless it's early on and the condition is still healing from the surgery itself. But let's just say we're 3 months down the road. That's not the case, probably. Now let's take the other possibility, which is going to be things around the hip. So first we had inside joint, now we have outside joint, we have referred to joint, and then we have overuse or mechanical changes. So the around the hip one would be things more like psoas, muscle, tendon, TFL muscle. You can even include local nerve involvement, such as the ilioinguinal nerve, iliohypogastric, the laterofemoral cutaneous. These are all sensory-based nerves. They don't really have motor function. I'm sure someone will correct me. Probably one of them has this one small motor function. But generally speaking, they're sensory. So they hurt, but it's not like you lose any like strength in the hip. So these are all possibilities here. And I'd say these possibilities are probably going to be higher with probability with this type of scenario than someone than having category 1. Category 3 is actually, I think it's more common than the other two. Referred from spinal components is actually very common. When someone has past hip impingement, they have mechanical changes which become habits. And so anterior pelvic tilt, which couples with lumbar extension or lumbar hyperextension, can create compression on the facet joints or the nerves as they exit outside of the spine, which we've covered on different podcasts and videos before. And they create the sensory nerves that go down into that area as well. So it's hard to say it's going to be one or the other, since these scenarios tend to go hand in hand with the mechanical changes associated to the old pain, as well as how long the person's had it. So there's also the possibility of referred pain. There are some pictures I put on recently onto our YouTube Shorts feed that have referred trigger points or trigger point referral locations. So there's a great book out there by Travell and Simmons, and it's been out for decades now. I'm sure probably I saw it, and it was older back when I was in grad school in the 2000s. When I was actually being treated as a patient back in the early 2000s. And basically what happened was, if you go online, you look up trigger points, and and you see trigger point of the TFL muscle, the psoas, you'll see all these red dots everywhere. And these are where people started to mention where they felt things associated to um, uh, trigger points in those muscles. And you can see that they go all over the place. They can simulate all these different types of conditions. They will drive you absolutely insane if you start chasing down these symptoms in the wrong area. So you might as well just identify that they possibly could be coming from those muscles. And after having a surgery, it's a traumatic experience, and it happens. It's a side effect associated to it. It's normal. I know if I got punched in the arm, I would probably have some side effects for a little bit of time too. And so what this does is it creates a possibility of having intramuscular trigger points. But also too, to be fair, the person's been having probably altered gait or walking for a long time. They've been in pain for a long time. They've been guarded, as we do when we're in pain. So there could be trigger points associated to the problem which were there previously as well. And the last thing is going to be overload principles. I would suggest watching our newest YouTube video, our long format one about hip impingement. I spent a lot of time on it. I'll link it in the show notes here for the podcast player. But if you're on YouTube already, just go to our channel. It's at the bottom, and then search on our sidebar of. You just search our videos, and you can find the most popular, the recent ones, etc. It's one of the most recent ones as of today, which is beginning of August 2025. And I show all of these. I show a bunch of different types of altered loading strategies. One of them is a squat that you drift to the side. It's common that people who have hip impingement or symptoms associated to hip impingement on the right side, actually, when you have them do a proper assessment and their feet are in a standard position, not the flared out position that you squatted in the gym, it actually it actually reveals more of squatting into the side of the stiffness or the impingement. And so this could create pain with a lot of different people who actually don't have current hip impingement. It's kind of like, I think Stuart McGill made a analogy years ago about, I think he called it the butter and the bicep. He said, on the surface, a stick of butter is very benign, and if you hold it for hours, your biceps will slowly start to scream. And that is an example of excessive load over time and not really using the body as intended. And so ideally in those scenarios, we would try to identify the area or the reason why the person is shifting load to that side, and that would be part of the solution. So as you can see, there are many possibilities of why this person can still have problems after the fact, but I think it's crazy to blame that these problems can only be associated to joint issues. There's plenty of different reasons why, and you can go onto your AI searches and so on. Why do I have groin pain? And they'll give you endless reasons. Now, identifying the right one, that usually is narrowed down by a healthcare provider skilled in assessing the hip, also in movements, and that helps you stop wasting time. But there's plenty of great stretches and exercises on YouTube, but figuring out the right one to do that can be the confusing part. So if you guys want any help from us, we also are real people, and we see people virtually and in person. 714-502-4243, or you can check out our website, p2sportscare.com, and all the great reviews we've had with some of our telehealth sessions. So if you're listening to the podcast player, again, we are going to be releasing these twice a week. And on YouTube, I'm going to do my best to do this around this time of day. I can't give you a definitive schedule. As you see, I'm driving to work, so I'm just doing it whenever I can. We'll see you guys next time.